All right, good morning. I'm having to redo this video because the previous one did not take. So I'm going to start this one with bowel disorder drugs and looking kind of starting around slide 3. So remembering just generally what is diarrhea, and we know that just because somebody has one loose stool doesn't mean it's diarrhea, right? And we know that with diarrhea symptoms we certainly can have, it's more that very loose or watery and you have abdominal cramps. Sometimes you can have a fever depending on the causative nature, bloating. Acute diarrhea again is lasts anywhere from 3 to 2 weeks and it's more self-limiting, but chronic can be 3 to 4 weeks or more, and just again depending on maybe that medical condition. Um, okay, just the goals of the diarrhea treatment is again we want to try to alleviate the stool frequency, and if they're having those abdominal cramps, the pain, replenishing their fluids and their nutritional deficits, so just monitoring again for that dehydration and so more. When we talk about bowel disorder drugs, again, we're talking about drugs that can affect, so think of that motor activity or the motility of the GI tract, that word peristalsis that we talked about, which again is that rhythmic wave-like contractions through the gut. And when you think with the nerves that innervate that GI system, that is like a big deal. So when you're doing medications, you're looking at how really it can impact that nervous system. Okay, so we know we can give medications to speed things up or to slow things down, just depending on what's going on. When it comes to laxatives and antidiarrheal, we want to make sure patients are not addicted. And it can be a younger person, but we do know again that older adults do tend to have more laxative abuse and more fixated on their stools. So going back to again assessing, what is your normal bowel pattern? How many times a day do you normally go, or do you go every other day? And are you using any kind of stool softener, stool laxative, enema, suppositories, all that would come under that umbrella of laxatives. And again, too, older adults are definitely more sensitive to side effects or adverse effects with laxative use, and they have a harder time sometimes with that fluid imbalance and cardiovascular effects. So keeping in mind any of the medications we talked about, what is that goal? What is the therapeutic actions? Why are we giving that medication? So if somebody's having diarrhea, we would be looking at an anti-diarrheal. So again, that anti meaning we're going to go in there and we're blocking something or inhibiting something. And so with the diarrhea, the GI tract is just like overly stimulated. And so that's going to go in there and slow that motility down, so that way we can get that diarrhea under control. Looking at the different types of antidiarrheal, so the adsorbent is the example is the Pepto-Bismol. A few things to remember about that. They said that can go in there and it just coats the walls of the GI tract, but then it can be used, like I said, for people that are not having diarrhea. It is a good to help also coat the GI tract to prevent irritation. But if somebody is having diarrhea because of like a bacterial source or something, the medication not only coats the wall, but it will attach to that bacteria and help to actually eliminate and try to get rid of that bacteria. Again, it has that component of salicylates, which is aspirin. So some contraindications for this medication comes back to children and teens. And we do know again that it can cause the tongue to be black and the stools to be dark as well. Okay. The anticholinergic, so remembering a few things with that, it is kind of, the example was the belladonna alkaloid, sorry. So it's kind of like going in with the anticholinergic. It's really working on the parasympathetic nervous system because the PNS is at rest and digest. And so I think the biggest thing I would have you know is with the anticholinergics, again, going back to thinking of what the PNS does, if I'm blocking it, what are those things that I'm seeing? And we know that it is contraindicated in some people, right? and that it can cause those very dry mouth, the urinary retention, the facial flushing. Anti-motility drugs that fall under the opiates. So again, you can have opioids that are used more specifically for pain, like we talked about. However, side effects of opioids just is constipation. But the medications we talked about during the lecture, like the paregoric, the Imodium, the Lomotil, they are considered opiates, but not used for pain control. They're opiates that are used for diarrhea purposes, or sometimes people are having like they have IBS, they can have diarrhea, or sometimes they go have constipation. But these are, because they're opiates, again, we know that one of our goals is to see if they're being beneficial, but again, making sure that people do not abuse the medication, because you can get that kind of euphoric feeling from some of them. Probiotics, we know, will help to replace the good flora, bacterial flora in the gut. The bacterial flora in the gut can get off kilter through different ways. And so that healthy bacteria is really important for digestive health. And so some of the examples is the acidophilus, or naturally is the yogurt. It has a lot of probiotics. Okay. Just to keep in mind, I already talked about some adverse effects from the antidiarrheals as far as the discolored tongue. Let's see, dark stools, and again, because of that salicylate in there, people can have increased bleeding time. So always making sure we're looking to see if they are already on any kind of blood thinners. You can review the slide about the anticholinergics with the side effects, and then again the opiates with potential side effects. Okay. With the, I don't know if we talked about, let's see, the adsorbents, and looking at what were some other interactions, because again, even though some of these, a lot of these are available over the counter, does not mean that they cannot react with the patient's prescribed medications. So we want to be very aware of some potential interactions that can happen from these antidiarrheal medications. And so we're looking at, again, are they on anticoagulants? Are they on any kind of cardiac medications? Are they on methotrexate, which is, again, for rheumatoid arthritis? Sorry that I keep moving the camera. As always, with anything, we're talking about thorough history, again, bowel pattern, careful use in the elderly, looking to see if anybody has had, if they have any clotting disorders, any recent bowel surgery. Do they already have some confusion, or if they have a newly developed confusion, is because of the medication. We know some other contraindications about the anticholinergics, and it had for people that have the glaucoma, GI obstruction, the paralytic ileus, that megacolon. We just want to make sure that patients take their meds as prescribed, that we are absolutely looking at their mucous membranes and other things for dehydration status. Okay, looking for that therapeutic effect. So again, is it that we're seeing a less of them, less bowel movements, maybe the stool's becoming more firm. Okay. We do know that a little too much use of antidiarrheal can cause the opposite effect with constipation. So now we're going to flip over to constipation. Again, you know what the definition is, and that most laxatives, again, that are available over the counter, and so you don't need a prescription for them. And individuals, again, can really get some very chronic intestinal disorders as a result of abuse from them. They just become too dependent. Okay. And so we're going to talk about a few of the different types of laxatives. Okay. So the bulk forming, keep in mind again, this is the only one that's safe for long-time chronic use. It will help to pull water into the intestinal tract and bulk up the stool, and then that will cause the reflux, natural reflux for the patient to have a bowel movement. Your examples again, like Metamucil and Miralax, Fibercon, Citrusol. Okay. So looking at some side effects of it, that we do know that usually the main things with those laxatives can be that abdominal bloating, the flatulence or gas, sometimes upset stomach, but really it can be, like I said, really kind of that bloating and gassy feeling. Okay. We know with emollients, these are the ones that's more of that lubrication or stool softener. So it will, again, helping to kind of pull the water in, but also they're going to go in, those emollients go and coat inside of that GI tract and try to soften the stool up so that patients can have an easier time passing the stool. Okay. Hyperosmotic, so thinking again that process of osmosis and just like a hyper, like and ramped up osmosis in a way. So it's going to draw in more of that water. It's going to stimulate the GI motility because now I want to get the GI right revved up and going where before I needed to calm it down. So one of the examples was the polyethylene glycol, the PEG, which yes, it is Miralax, but this is made a little differently when you're looking at the ones who are going to take it for bowel prep. So for surgical procedures or those colonoscopies where you have to get totally cleaned out so the physician can look inside that colon well with that scope to see if there's any abnormalities. Okay. Sorbitol, lactulose also comes under the hyperosmotic. And again, we know lactulose can be given as a laxative, but again, if you see it on somebody's MAR, they ask you about it. It can also be used for folks that have some kind of liver disease and they get elevated ammonia levels, and the goal is to reduce those ammonia levels, and how we do that is by that patient excreting it through the stool. Well, you need to think about it, we can't have them just one stool a day. That's, they have to have multiple bowel movements a day in order to help facilitate that lowering of the ammonia level. Some saline laxatives examples just your Mag, your Citroma, or the magnesium citrate. And again, those are the ones that are Mag. I think both of these are kind of powerful, but the citrate of Mag you see as well. People use it for bowel preps or again that colonoscopy or procedures. And so again, it is pretty powerful if they take the whole bottle, which sometimes they have to. Just depends. The stimulants, so again, these are going to try to increase that peristalsis by increasing that intestinal stimulation. And these are your Senna and Biscodol, or Senocot and Dulcolax. And again, it would tell you on the box, usually, can give relief of symptoms within sometimes 6 to 12 hours. But again, I do find that patients will get abdominal cramping and bloating, sometimes from the stimulants. Okay. We talked about on the slide 37 about the peripherally acting opioid antagonist, and this was the Relistor or the Intereg, and that one again is used for patients usually a lot of times post-surgical in order to prevent constipation, but it will not prevent the opioids from working on the pain receptor. So patients will still get control of their pain without getting constipated with this medicine. Again, you may see it in long-term opioid use patients or hospice patients, but a lot of times you'll see it again for those acute post-surgicals. Different causes of constipation. So we said, lifestyle certainly plays a factor, right? So maybe not keeping themselves hydrated, lack of movement, low fiber diets, things like that. Endocrine disorders like thyroid disorders or neurogenic disorders like spinal cord or MS or Parkinson's. You can just review again the indications for laxative use, but if you just kind of keep in mind too, like some of them that are more basic for, hey, this person has, maybe an acute constipation or they have a chronic because of an underlying chronic health condition. So those people are more under those bulk forming or the emollients, which are more mild versus folks that are going to go in and have a surgical procedure or a colonoscopy or something like that, and you need more powerful, and those are your hypertonic or hyperosmosis, the saline. And the stimulants can kind of fall under sometimes too that, okay, you know what, I'm having a constipation, I can do this one time. Sometimes you'll see the Dulcolax also included in a bowel prep though as well. So it's very physician driven of what medication they use to prep their patients for. Some just adverse reactions, as we said, with that bulk forming, you have to have that lot of fluid to avoid the medication from like sticking in the throat and so forth. Because remember, you're trying to pull in the water and it's going to bulk up. So if you don't take it with a lot of water, it can give you that obstruction in the esophagus. The whole theme through these laxative uses is monitoring of those electrolytes. And to, again, we want to make sure that, yes, we're trying to get the patient cleaned out. Let's say if it is for a bowel prep or a colonoscopy, but if it was just to treat constipation and they develop diarrhea, then that's another issue. Again, we do tell patients to not take laxatives if they're having some type of abdominal pain, nausea, vomiting. We really don't want to administer something without first diagnosing that patient and knowing what's the cause of that abdominal pain. Okay. So as far as patient education, again, naturally, lifestyle modifications increase the fiber, increase fluid, increase mobility if able. And then just that recommendation of 6 to 8 ounces of water with all laxatives. But for the bulk forming, that minimum of 8 ounces of water. Okay. All right. And then always, we tell patients if your symptoms are not relieved or if they're worse, they should follow up with their healthcare provider and not just continue to use these products. All right. So that is it with the bowel motility. Okay, so we're now jumping over to the antiemetic, anti-nausea. So again, antiemetic, thinking what does emesis mean as vomiting. So we certainly know that we can go two ways. We can give an antiemetic or we can give an emetic. And I don't think we talked about it yesterday. With the emetics, you can actually do have medication to induce vomiting because you want to get rid of those toxins or drugs that's in that gut. So when you think about a lot of parents will keep on hand that Ipecac of syrup or something like that, or there's other medications that can be given in the ER setting to induce vomiting because you need to get it out. The one thing is though is that you caution that if it is something that was more alkali or acidic that that person ingested, then that might not be warranted to give that emetic because chances are it's going to cause a chemical burn on the way down, and if you bring it back up, it can irritate and cause that chemical burn on the way back up. But just so we know that there are medications to produce vomiting if needed. Again, that what we have in our brain in that medulla is that chemoreceptor trigger zone, or the CTZ, and that is the area of the brain that's going to respond to those different stimuli. And again, the brain and the gut have almost like their own nervous system of that highway of communication. Again, looking at across the lifespan, so the antiemetics, what I would say, is a lot of times more prevalent in certain situations as far as post-surgery, chemotherapy. If somebody maybe has some underlying pathology that they battle with nausea often. Older adults, again, can be more sensitive to some of these medications. So again, we're just monitoring for that. We'll look at some of the different classifications of the antiemetics. So with the anticholinergics, one of them we talked about was the scopolamine or that transderm, and this is again used for people will use a lot for motion sickness, and or it's like if they're going on a cruise or on a boat for the day or flying, just different things. It is a patch that tends to go behind the ear. Again, we change it every 72 hours. And remember, keep in mind the education piece is what are those anticholinergic side effects, and that we're educating our patient on those. With antihistamine drugs, so this is the H1 receptor blocker, not the H2, but the H1. And so it goes in there. A lot of people take these again for allergies. Sometimes they'll take it because it is very sedating, the Benadryl, and they'll take it just for rest issues. And so the antihistamine receptor blockers, again, what happens to go in there and try to block histamine and effects that we can have like in the brain, and then again, the inner ear and the brain also very connected with the communication. And so trying to block some of the receptors within that ear and so forth to try to counteract the nausea. The antidopaminergic or antidopamine is your compazine, Phenergan, droperidol, and I think, like I said, the compazine, these are still in use, but we talked more about the Zofran, and I'll get to that in a minute. The one that we talked about was Reglan, and Reglan you will see as either kind of twofold. They can put it under the nausea because patients can have nausea when they have a slow peristalsis. So things are kind of backing up and they're not digesting well. The Reglan will stimulate that GI tract with the peristalsis and get things moving, and that will help try to relieve the nausea. The thing is with the Reglan, this is the one that can potentially cause that neurological condition called tardive dyskinesia, where patients will have that abnormal kind of like head twitching and mouth movements, like smacking their lips, sticking out their tongue, rolling their tongue, things like that. So the Zofran is a serotonin blocker. This is, again, the most common antiemetic medication. We see it used now really across the board. But one of the things we talked about, it is great post-surgery and for your chemotherapy patients. And keep it in mind is that timing of when do we want to give the Zofran is very important, because we want to try to ward off potential nausea when we can. We talked a little bit about the tetrahydrocannabinoids, which is your marijuana derivatives, and the example was drobinon, Marinol, and it starts with a D, dronabinol. I could say it yesterday. Anyways, we do know that folks can take this for twofold again. As you have a lot of patients that, if they're nauseous, they don't want to eat, or because of side effects of medicine. So it will help to relieve nausea, but it also can be used as an appetite stimulant. So kind of that twofold. We talked about Imitral and Amend, and Imitral is the one that can be used for morning sickness, even though that's not the FDA label purpose. So that's what that off-label means. And then the Amend is also something that can be very widely used for chemotherapy patients. And thinking about adverse effects, it just really goes back to, again, because a lot of these, again, thinking about right? Anti is going to go in there and block something or inhibit. So depending on what receptors these are blocking, that will guide more of those adverse reactions or effects. Herbal products, so ginger we know is great for GI issues, just a variety of things. But the one probably thing I would say with the ginger is just because it can interfere with patients' actual prescription medications. So we are looking at what kind of oral medications are they on prescription-wise, and especially if they're on an anticoagulant, that it can increase their chance, I want to say chance of bleeding, but their bleeding time or chance of bleeding. Okay, just assessing again patients' medical history, because again, is this a new acute onset of nausea, vomiting, or is this something that's been going on for a while? And this is one of those, again, to keep in mind with your old carts as far as, when did it start? What is the quantity? We talked about what does it look like, because that's very important as well, right? Maybe how many times a day did anything seem to make it worse or better? With the antiemetics, sometimes again they can cause drowsiness, and so a couple things we're educating our patients is caution when driving or performing any kind of hazardous task, to avoid alcohol, and that because it can give you some hypotensive effects, patients want to change their position slowly. We talked about chemotherapy. The antiemetics are potentially, we want to try to give them 30 to 60 minutes prior to chemo starting, looking for therapeutic effects, which again would be, hey, how is the effectiveness? Do you feel any nausea? Do you feel less nausea? Is it working? Okay. And then you can just eyeball the nursing process, which is still just kind of stays the same for no matter what we're doing. All right, I think that is it, guys. Have a great week.